A very good morning to all of you, and I welcome you all for today's series of lectures on nephrology and the intensivist. So, over years of practice, I understand that for you to be a good clinician, you have to be a good physiologist and a pathologist also. Unless you understand the physiological process, you won't be able to understand the pathological process and you won't be able to treat your patient. So, to start off today's series of lectures, I'll be talking about the renal physiology. To understand the renal physiology, you should also have some gross idea about the renal anatomy. Kidneys are a pair of bean-shaped structures which are located in the abdominal cavity retroperitoneally. The right kidney is slightly located lower than the left kidney because it is pushed down by the mass of the liver, and the left kidney is slightly located medially compared to the right kidney. Each kidney has a convex and a concave surface. From the concave surface, the renal artery, vein, and the ureter emerge out, and this is called as the hilum of the kidney. The size of kidneys are roughly about the size of a closed fist, and they extend from the T12 to the L3 vertebra. They weigh about 135 plus or minus 15 grams, and they are slightly heavier in males compared to females. Each kidney measures about 4.5 inches in length and 2.5 inches in width. Kidneys are highly vascular structures and complex structures. Kidneys are surrounded by many layers, both externally and internally. Externally, it is surrounded by a capsule, the perinephric and the paranephric fat, and the renal fascia. Apart from these layers, additional protection is also provided by the ribs, and the kidneys are covered by the peritoneal cavity, the peritoneal lining, and the fascia transversalis. This is the gross anatomy of the kidney. Now let us look at the microscopic anatomy. As I said, kidney has many layers, both externally and internally. Internally, the renal cortex is the capsule is the outermost layer, which is a very thin, tough, and a fibrous layer. Beneath the capsule is the renal cortex, and beneath the cortex is the renal medulla. Each kidney has 8 to 18 lobes, and each lobe contains a part of the cortex and a part of the medulla, and this is called as the renal pyramid. The tip of the renal pyramid ends into a minor calyx, which ends into a major calyx, which in turn ends into the renal pelvis and the ureter, and this is how urine flows down. Now, to simplify the structure of the kidney, you can view the kidney as a unipapillary kidney, which is the common structure to most of the kidneys. It has an outer tough layer, the capsule, the cortex followed by the medulla, or the outer and the inner medulla. Now, nephron is the basic structure and the function unit of a kidney. Each kidney has roughly about 1 to 1.3 million nephrons, and by the age of 40, every decade, there is a drop in the nephrons by 10%, and by the time the total nephrons reach less than 30% of the total number, kidney failure sets in. Each nephron has a vascular component and a tubular component. The vascular component formed by the afferent arteriole, the glomerulus, the efferent arteriole, the Bowman's capsule, and the peritubular capillaries. The tubular component is formed by the proximal tubule, the loop of Henle, the distal tubule, the cortical collecting tubule, and the collecting ducts. Multiple nephrons will share a single collecting duct. Now, if you look at the afferent arteriole is slightly wider compared to the efferent arteriole, which is important for the glomerular filtration. As I said, each kidney has roughly about 1 to 1.3 million nephrons. Not all nephrons are alike. Certain nephrons are situated in the cortex, they're called as the cortical nephrons, and certain nephrons are situated deep down in the medulla, and they're called as the juxtamedullary nephrons. Cortical nephrons account to 80% of the total nephrons, and the juxtamedullary account around 20% of the total nephrons. Based on their location, they also slightly differ anatomically and also differ in their permeability and transport properties. The juxtamedullary nephrons have a longer loop of Henle compared to the cortical nephrons, and they also have a long, thin descending and ascending loop of Henle compared to the cortical nephrons. They secrete less renin compared to the cortical nephrons, and they also have a specialized vascular structure called as the vasa recta. Now, because they differ anatomically, they also differ in their functional properties. The nephron has a unique capillary bed, wherein the afferent arterioles drain into a capillaries, which in turn drains into an efferent arteriole. That is, if you look at an artery is draining into another artery. So this is a unique system and is an example of the portal system. Now, the tubular system. Tubular system, as the name as the tubular system is divided into multiple segments. It is because of the unique structure it has, and also each part of the tubule differs in its properties, that is the filtration and the absorption properties. The proximal convoluted tubule uh, follows into loop of Henle, which follows into the distal convoluted tubule, the cortical collecting tubule, and ultimately the collecting duct. The proximal tubule compared to the distal tubule is slightly longer. It has certain specialized cells which form a brush border like appearance, and this increases the surface area of absorption, which are not there in the distal tubule. The proximal tubule continues down as a loop of Henle. The loop of Henle has a descending limb and an ascending limb. The descending limb takes a U-turn, and this looks like a hairpin. Each part of the descending and the ascending limb again have a thick segments and the thin segments, and based on the location in the cortex or medulla, the proportion of the thick and the thin segment varies, and hence also they differ in their functional properties. This is the glomerulus, which is the filtering unit of the kidney. The afferent arteriole, the efferent arteriole, there are certain bunch of capillaries which is called as a tuft. This is a unique bundle of capillaries which is located between two high resistance vessels, that is the afferent and the efferent arteriole. This tuft of capillaries is present in a cup-like structure called as a Bowman's capsule. The glomerulus along with the Bowman's capsule is called as the renal corpuscle. This is the only capillary bed in the body that do not have or that are not surrounded by the interstitial tissue, and hence they need a unique support system to maintain the flow. The two specialized cells present are the juxtaglomerular cells and the macula densa cells. Juxtaglomerular cells are so named because they are present in the JG apparatus, which is nothing but it is so named because it is just present adjacent to the glomerulus. It is found between the afferent arteriole and the distal collecting duct. This position is critical for its function in regulating the renal blood flow and the GFR, and it takes part in renal autoregulation. Now the macula densa. The afferent arteriole enters and the efferent arteriole leaves the Bowman's capsule. The tubule of the nephron here touches the arteriole of the glomerulus, and at this location the distal convoluted tubule changes or modifies into a specialized cells called as a macula densa, which are responsible for changes in the sodium chloride content of the body, and hence they take part in the tubuloglomerular feedback mechanism. Now, this is the glomerulus, which is the filtering unit of the kidney or the filtering unit of the body, and it is a high pressurized unit. It again has three layers. This is the innermost layer, which is the endothelial layer. Between the endothelial cells there are large holes which are called as the fenestrae, which contains glycocalyx, and this is negatively charged. So this layer will not allow passage of negatively charged substances. Now this is the outermost layer, which has simple squamous epithelial cells with unique shapes, that is they look like a food processor or porocytes, and they have finger-like extensions. Between these are slits. The slits are lined by the diaphragm. These slits doesn't allow passage of larger molecules. Now between the endothelial layer and this epithelial layer is the basement membrane, which contains type 4 collagen, the nephrin. The absence or mutation of this nephrin leads to congenital nephrotic syndrome. So the glomerulus contains three layers: the innermost endothelial layer, the glomerular basement membrane, and the outermost porocytes or the food processes. This is the filtering unit of the kidney. Because of its unique anatomical structure, it does not allow passage of blood, larger proteins, and negatively charged substances. So if your glomerular basement membrane or the glomerulus is damaged, that is, if there's a glomerular disease, then only you see protein or blood in the urine. As the structure of the kidney is complex, so also is the functioning of the kidney. Kidney takes part in multiple functions of the body. It regulates the osmotic pressure of the body either by excreting a dilute or a concentrated urine. It regulates the concentration of numerous ions in the blood plasma like the sodium, potassium, calcium, magnesium, chloride, and so on. It plays an important role in the acid-base balance, either by excreting the H plus or the HCO3 minus ions. It regulates the volume of ECF by controlling the sodium and water content of the body. It regulates the arterial blood pressure by its control on the sodium and water content, and also because of the renin production. It eliminates the waste products of metabolism, being urea, uric acid, and creatinine. It plays an important role in drug metabolism and excretion. And kidney is a site of synthesis for various hormones like the erythropoietin 125 dihydroxy vitamin D3. So kidney takes part in multiple functions, but the basic function of the kidney is to excrete waste products by urine formation. Each glomerulus filters the plasma, and this filtration varies based on the location of the glomerulus and certain physiological and pathological conditions. So each glomerulus will have a unique GFR, and the combination of the GFR of all the nephrons is the GFR which we are calculating. The movement of water across the glomerulus follows the Starling forces. There are three basic mechanisms for the excretion or urine formation, which are nothing but filtration, the reabsorption, and secretion. Filtration takes place in the glomerulus. Reabsorption and secretion takes place in the tubules. Filtration is a non-selective process and a passive process, whereas reabsorption and secretion are selective process, and this can be either active or passive. Now, as I said, filtration takes place in the glomerulus, and it follows Starling forces. As the plasma flows through, it is filtered in the glomerulus, reabsorbed in a part of the tubule, and secreted in the other part of the tubule. The composition of the fluid in the glomerulus is similar to that of plasma because it is just simply filtered, whereas the composition of the fluid in the tubules is different compared to that in the glomerulus because reabsorption and secretion takes part in the tubule. So the ultimate product which is excreted is different from the filtered product in terms of the solute and the solvent content. So for you to calculate the excreted amount, you should know the filtered amount, what is reabsorbed and secreted, and the reabsorbed and the secreted product minus the the filtered product minus the reabsorbed plus the secreted product will give you the ultimate excreted amount, which is the urine. Filtrate, as I said, in the Bowman's capsule is similar to that of plasma, unlike the final excreted product, which is different in its both solute and the solvent content. The reabsorption, as I said, is a selective process. Reabsorption occurs, there is reabsorption of certain solutes like the sodium, the chloride, the calcium, glucose, amino acids, and certain substances are secreted like the organic anions, the organic cations, the para-aminohippuric acid, etc. Reabsorption is nothing but simple movement out of the urine into the blood, whereas secretion is nothing but simple movement from the blood into the urine. So these two processes, that is reabsorption and secretion, can be either active or passive. They depend on the substance and certain other clinical conditions. Now, renal functions can be measured by measuring the filtration, or by measuring the reabsorption or secretory properties, or by measuring the renal blood flow. So to measure the renal function, you should know about the renal clearance. Renal clearance is a useful way of looking at a kidney function. Renal clearance is nothing but you can simply think of kidney clearing substance from your blood or plasma. Now, the substance excreted will be a certain amount of substance which is filtered from the blood, and your blood is freed from that certain amount of substance. That is, your plasma is freed from certain amount of substance. This will depend on the flow rate and the concentration of the substance in the urine or plasma. For suppose X is the substance of interest and C is the clearance of the substance, where U is the urinary concentration of the substance X and P is the plasma concentration of the substance X, and V is the urine flow rate, and the ultimate final product is given in terms of milligrams per minute. The concentration of the substance in the urine and plasma and the urine flow rate will help you calculate the clearance of that substance. As I said, to know the renal clearance, you should also have some idea about the renal blood flow. So as I said, kidney is a highly vascular structure. The kidneys are supplied by the renal arteries. Renal artery is a direct branch of the aorta. The renal artery further divides into segmental arteries, which further divide into interlobar, the arcuate, and the interlobular arteries. Kidney has a special property of autoregulation. That is, it can regulate the blood pressure over a high range of the mean arterial pressure ranging between 80 to 180. Renal blood flow is close to 20% of the cardiac output. That is, it is a highly vascular structure because it has a high rate of perfusion. This high blood flow is required for the high GFR. The oxygen concentration is roughly about 8% of the resting oxygen concentration, but the kidneys receive more oxygen, and as a consequence of which even the venous blood is bright red in color. Now, anatomical arrangement of the renal arteries is such that the arterial oxygen is shunted into the veins before it enters the capillaries. So oxygen tension, unlike we think, is not high, and kidneys are sensitive to ischemic changes. Though it is receiving roughly 20% of the cardiac output, and though it is receiving much more oxygen than what is required, this oxygen is also shunted into the veins before the blood enters the capillaries, and hence though it is getting high oxygen, kidneys are prone for ischemic changes. That is, they are sensitive to ischemic changes. Now, blood flow is again highest in the renal cortex compared to the medulla, and this low blood flow in the medulla helps to maintain a hyperosmolar environment in the medulla. As I said, autoregulation is a unique feature of kidney. That is, despite changes in the mean arterial pressure between 80 to 180, kidney will regulate, that is, maintain a constant blood flow. And this property can be demonstrated even in an isolated, denerved, and a perfused kidney. GFR also follows the renal autoregulation. So GFR is also fairly maintained between this blood pressure ratio. Below the autoregulation and above the autoregulation, both the blood flow and the GFR will change appreciably according to the blood pressure. Two main mechanisms are responsible for maintaining this renal autoregulation. One, the myogenic, and other is the tubular glomerular feedback mechanism. The myogenic mechanism is simply nothing but whenever there's an increase in the blood pressure, there occurs vasoconstriction, so the blood flow will decrease and vice versa. The tubular glomerular feedback mechanism is an important mechanism, is maintaining the renal autoregulation. Whenever there is an increase in the GFR, there occurs an increase in the blood flow and the capillary pressure, and also there occurs an increased delivery of sodium chloride to the macula densa, which causes an efferent arteriolar constriction and ultimately decreases the blood flow. That is, this tubular glomerular feedback mechanism is a negative feedback mechanism that exists in the kidney. Now, this is the renal blood flow data, which we should know. Renal blood flow, as I said, is roughly about 20% of the cardiac output, which is around 1 to 1.2 liters per minute, and 90% of it goes to the cortex. The renal plasma flow can be calculated from the renal blood flow and the hematocrit, which is roughly about 5 to 600 ml per minute. GFR is about 20% of the renal plasma flow, which is around 100 to 120 ml per minute. So the GFR is around 120 ml per minute. That means the filtration is around roughly around 7.5 liters per hour and 180 liters per day, of which the final output is only 1 to 2 liters. That means close to 178 liters is being reabsorbed by the kidney. Now, to understand the renal functions and to calculate the filtration rate, reabsorption rate, and secretion rate, you have to understand this particular model of the kidney. For suppose, take a substance A. This substance A is only filtered by the kidney, but it does not undergo any reabsorption or secretion. So whatever is filtered will be equal to the excreted rate. That is, your GFR will be equal to the clearance. These two substances which are filtered but not reabsorbed nor secreted by the kidney are inulin and creatinine. Inulin is the gold standard. So if you have to measure the GFR, you have to use the inulin clearance, which is the gold standard for measuring the GFR. Creatinine is slightly closer to inulin, though it has certain pitfalls. That is, the creatinine clearance estimate has two drawbacks. One, there are errors in the measurement of the plasma creatinine, and so also creatinine is partly secreted by the kidneys, which may be a negligible amount. That is, if you look at the creatinine clearance formula, wherein you are looking at the urinary concentration of a substance multiplied by the flow rate divided by the plasma concentration of the substance, for the creatinine, there is slightly false high values both in the urine and plasma. In the plasma because of multiple conditions, in the urine because it is partly secreted. So the numerator and denominator, these two errors can cancel each other. So clinically, creatinine can be used in place of inulin for measuring the GFR. So the creatinine clearance roughly equals to GFR, which is nothing but your renal clearance. Now, certain substances undergo filtration and completely they are reabsorbed. Like for suppose 10 molecules of sodium are filtered, they are completely absorbed. So there is no amount which is excreted. So here your creatinine clearance becomes zero. Example of such substances are the glucose and amino acids. Now, certain substances are filtered, they are not reabsorbed and secreted. So that means if for suppose a substance X is present in a concentration of 10 milliequivalents in the glomerulus, the concentration in the final urine product will be much higher. This is because it is also secreted by the kidney. Here, the creatinine clearance will be more than your GFR. The examples include your bases, the organic anions, and the cations, that is your organic acids, and the pH. So by these substances which undergo filtration and secretion, you can measure the renal plasma flow and the renal blood flow. Now, there are certain substances which undergo filtration, but they are only partly reabsorbed and not completely reabsorbed. That is, their concentration is slightly lesser in the tubular part compared to the filtered part. So here the creatinine clearance will be less than the GFR. Such substances are the urea and electrolytes. Urea is only partly reabsorbed, not completely reabsorbed like the glucose and ammonia. So if filtered amount is equal to the excreted amount, that is, it is only getting filtered but not reabsorbed nor secreted, then you can calculate the creatinine clearance. Clinically, you can use creatinine for this. If the filtered substance also undergoes secretion, the creatinine clearance is higher than your GFR. Such substances can be used to measure your renal plasma flow and the blood flow, example being PAH, para-aminohippuric acid. If the filtered substance is completely reabsorbed, then your creatinine clearance will be 0. That means you cannot find such substances in the urine. So you do not normally find glucose or albumin in the urine unless there is a problem with the filtration or the reabsorption. For the creatinine clearance to double, your GFR should decrease by 50%. That is, it takes certain amount of time for the GFR, for the drop in GFR to be evident as an increase in creatinine clearance. Now, look at this glucose titration study to understand the glucose reabsorption by the kidney. Glucose is handled by the kidney. It is filtered, excreted, and reabsorbed. At a sugar value as low as 100, all of it is reabsorbed and nothing is excreted. There is no excretion. It is only completely absorbed. Now, when the glucose level increases to 200, it starts appearing in urine, and this is called as the glucose threshold. Now, if you further increase the blood glucose levels, more and more of it is excreted because the filtered amount exceeds the tubular reabsorbing capacity. Now, at some point of time, this reabsorption capacity will reach a maximum, and this is called as the tubular transport maximum for the glucose, that is TTM maximum for the glucose. This glucose threshold depends on the tubular transport maximum for the glucose, the GFR, and the splay. Splay is nothing but just rounding off the reabsorptive curve. If, for suppose, the filtration decreases for some reason, that is, the filtered load of the glucose decreases, all of the glucose will be reabsorbed. So clinically, for suppose, if you have a patient with a decreased GFR, that is, you have a patient with an acute or a chronic kidney disease where the glomerular filtration decreases, in spite of them having a high blood sugar, you will not see glucose in urine because the filtration capacity is dropping. So the kidney is not able to filter all the glucose. Here the reabsorption capacity is normal, so it is completely reabsorbing. So in spite of having a high glucose in the blood, you will have a false assumption that glucose is not being filtered because the blood glucose is under control. No, this is a false negative test. That is, you won't have glycosuria in spite of having a high blood sugar if your glomerular filtration for some reason is low. Now you can look at the tubular transport maximum for PAH, and you can assess the proximal secretory function. At low plasma PAH levels, secretion increases, and at a high PAH levels, secretion almost stabilizes for the PAH. Now, that means at some point, it also reaches a tubular transport maximum for PAH. This tubular transport maximum is directly related to the number of functioning proximal tissues, and hence it is a measure of the proximal secretory tissue. It measures the mass of the functioning proximal secretory tubule. PAH is secreted by the tubules. So if the if the content of PAH is low, it secretes. If the content of PAH in the tubular fluid is high, the secretion stabilizes. Rather, the secretory curve flattens. So by measuring how much is being secreted, that is by measuring the tubular transport maximum, you can measure the mass of the functioning proximal secretory tubules. Now, as I said, the glomerular has 3 layers, which we have already discussed. Just remember that the glomerular fluid takes an extracellular pathway, that is from the endothelium, it passes the basement membrane, and from there it passes through the pores in the food processes. And as I said, glomerular filtration is dependent on many factors. It is dependent on the net ultrafiltration pressure, the plasma flow rate, the ultrafiltration coefficient, the molecular size, shape, deformity, and electrical charge of certain substances. So size, substances which are smaller than 10,000 kilodaltons are easily filtered, whereas larger molecules are not filtered. Substances which are long and slender can easily pass through the gap in the porocytes, whereas spherical substances find it difficulty to pass through. Deformable substances can easily pass through because of the shape of the slits between the porocytes. And because the basement membrane is negatively charged, it repels the negatively charged particles, whereas positively charged particles can easily pass through. Now, if you look at the filterability, that is the filtrate to the plasma water content, if the filtration is 1, that is it is completely filterable, that is water is completely filterable. If this ratio is less than 1, see for the serum albumin is 0.001, that means it is not filterable, it is only it cannot be excreted by the glomerular basement membrane. So if you see any protein, hemoglobin or myoglobin, it means that there is a glomerular disease, that is proteinuria, hemoglobinuria and myoglobinuria are a hallmark of the glomerular disease. Ratio of 1 suggests easy filterability, whereas a ratio of less than 1 says they are again reabsorbed, or they are rather not excreted. So to calculate the glomerular filtration rate, as I said, there are many factors dependent. The glomerular filtration rate is determined by the glomerular ultrafiltration coefficient and the net filtration pressure, which is nothing but this is the hydrostatic pressure of the glomerular capillaries, the hydrostatic pressure of the Bowman's capsule, and the colloid oncotic pressure. The hydrostatic pressure of the glomerular capillary is roughly about 55, the colloid oncotic pressure is around 30, and the hydrostatic pressure at the Bowman's capsule is 15. So the net ultrafiltrate pressure gradient comes to around plus 10 mmHg. Now look at the filtration that happens in the other capillaries, like the skeletal muscle capillaries of the body compared to the glomerular capillaries. In the other capillaries, that is the skeletal muscle capillaries of the body, the capillary hydrostatic pressure at the arterial end is higher compared to the venous end. That is, there is a sequential drop in the capillary hydrostatic pressure from the arterial and venous end, whereas the oncotic pressure, the colloid oncotic pressure, remains reasonably stable in comparison to the kidney, where the baseline hydrostatic pressure compared to the skeletal muscles is very much higher, and this hydrostatic pressure in the glomerulus and the basement membrane is uniform mostly throughout without much changes, whereas the colloid oncotic pressure slightly increases from the afferent to the efferent arteriolar end. So in the other capillaries of the body, where there's a constant drop in the hydrostatic pressure from the arterial to venous and the oncotic pressure remains more or less stable, there occurs a point where there is no filtration. This is called as a filtration pressure equilibrium. Unlike this phenomenon in the skeletal muscles, in the kidney, there is no such point. That is, at no point does the hydrostatic and the colloid pressure equilibrates, resulting in no flow. That is, there is no point at which no flow occurs in the kidneys. From the afferent to the efferent arteriolar end, there occurs always filtration. Whereas in the skeletal muscle, there is a point where the pressures equalize and hence no filtration happens, and such zone are not there in your glomerular capillaries, which is a unique property of the kidney. Now, each tubular segment, that is a proximal tubule, distal tubule, I said are different in its transport mechanism. So I'll just briefly go through the transport mechanisms in each part of the tubule. As I said, glomerular filtration is a non-selective process. By contrast, the tubular transport is a selective process, and this transport differs in various segments of the nephron. Now, the proximal convoluted tubule absorbs close to 70% of the filtered water. For the purpose of understanding, and also as the proximal straight and convoluted tubule functionally are similar, it is included as single unit. Now, to understand how much water is filtered, you have to look at the inulin and water concentration. At the beginning of the proximal tubule, the inulin concentration and water concentration are equal. So the ratio of the tubular fluid of urine containing the inulin and the plasma containing inulin will be 1, because water and inulin are present in equal concentrations. Now, for suppose as you go through, once water is reabsorbed by the kidney, inulin concentration will increase. So as the fluid flows through the tubules from the proximal end towards the end of the proximal end, some amount of water is absorbed. So there is a relative rise in the inulin content. So the ratio of 1 of inulin, that is the clearance of inulin of 1, rises to 3 by the end of the proximal tubule, suggesting that 70% of the water is reabsorbed. Now, in the distal tubule, the concentration lies somewhere at 4 or 5, suggesting that close to 80% of the water is reabsorbed. And at the beginning of the ureter, the ratio is more than 100, suggesting that close to 99% of the water is reabsorbed in the proximal convoluted tubule. Simply understand that if inulin is example, just I'm saying, if the concentration of inulin is 10 grams or 10 ml at the beginning of the proximal tubule, and water is also same, as inulin and water pass through the proximal tubule, only water is reabsorbed. So the relative concentration of inulin is increasing, which will help us tell the amount or the percentage of water being filtered. So based on the tubular fluid concentrations of inulin in urine and the plasma, we can roughly determine the percentage of water reabsorbed. And this is 70% by the end of the proximal tubule. Roughly 80% of water is reabsorbed by the end of the distal tubule, and close to 99% is reabsorbed by the end of the ureter. Now, the fluid in the proximal tubule is essentially isoosmolar to plasma. High water permeability, because of the high water permeability, 70% of water and solutes are reabsorbed. That is, both water and solutes, the sodium, potassium, are reabsorbed. The tubular fluid to plasma concentrations, if it is 1, that means it is isoosmolar to plasma, because same amount, roughly equal amounts of water and the solutes are reabsorbed. if this concentration of the tubular to plasma fluid drops to below 1, that means most of it is reabsorbed. For us, like ammonia and glucose, they are completely reabsorbed. If the concentration of the tubular fluid to plasma are increasing in relative to water, they are less reabsorbed or they are secreted. Like urea is less reabsorbed, inulin is not at all absorbed, and PAH is secreted. So if the concentration falls, it is getting reabsorbed. If the concentration is rising, either they are partially reabsorbed or they are secreted. Now, as the concentration of the osmotically active substances increase, the sodium and water excretion also increases, resulting in the so-called osmotic diuresis, which we see when there is glucosuria. Sodium is reabsorbed against the concentration gradient in an active process. So there will be a fall in the sodium concentration, and this will result in an increase in the tubular diffusion of sodium, and finally decreased reabsorption of sodium and water, resulting in an increased excretion. Simply remember that whenever there are osmotically active substances in high concentration like the glucose or alcohol, there occurs excretion of sodium and water, resulting in the so-called osmotic diuresis. And here in the tubules, in the proximal tubule, osmolality is not much changed because the sodium and the osmotically active substance is the sodium, which is relatively in equal ratio to the water. So osmolality is similar. It is isoosmotic to plasma. Now, sodium reabsorption is the major driving force for reabsorption of solutes and water in the proximal tubule. In the proximal tubule, this is the apical cell membrane and this is the basolateral cell membrane. The sodium enters the cell downhill in X along with glucose, amino acids, and phosphates. The sodium that enters the cell exits the cell through Na plus K plus ATPase or along with the bicarb. This sodium which exits the cell gets absorbed into the capillaries and then into the blood. The Na plus K plus ATPase exchanged sodium to potassium, whereas potassium is pushed into the cell, and this potassium is excreted back or pushed back into the interstitial space independently or in exchange with chlorides. The glucose, amino acid, and phosphate which enter the cell leave independent to sodium. So all that is excreted into the interstitial space again enters the blood. Water enters separately to aquaporin channels, and again this is also absorbed into the blood. The entry of sodium into the cell is dependent on one, the electrical, and other the chemical gradient. The electrical gradient being the negative charge and the chemical gradient being the low composition of sodium inside the cell as compared to the amount present in the tubular urine. So basically sodium and water along with glucose, amino acids, and phosphates are mostly reabsorbed from the proximal tubule. This reabsorbed solute along with the solvent enter the interstitial space and enter the blood. Water enters independently compared to sodium. Entry of glucose, amino acids into the cell is along with sodium, whereas exit are independent. Now, the proximal tubule also takes parts in generation of organic, both anions and cations. This is the basolateral part of the membrane, and this is the apical part. From the basolateral side of the membrane, the anion, which is the para-aminohippuric acid, enters the cell through the organic anion transporter in exchange to alpha ketoglutarate, which enters the cell along with the sodium. Now the PAH which enters the cell leaves the cell by the anion exchange, the main anion being chloride, or through the multi-drug resistant channels. The organic cations enter the cell because of the charge difference from the exterior to the interior of the cell, and this is a passive process. This entry of organic cations and anions into the proximal tubule plays an important role in the acidification of urine. This acidification of urine and the entry of organic ions into the cell can be both active and passive process. This is an active process. The and there occurs also a passive process. Anions accept H plus, whereas cations release H plus. This results in a charge or change. This change is influenced by the pH. The acidification of urine converts anion into a non-ionized acid, which is reabsorbed by diffusion. NH3 is basically a lipid soluble base which diffuses into the tubular fluid, where it is converted into NH4, and this gets trapped in the urine. This results in the acidification of urine. The loop of Henle is again different in terms of permeability and transport compared to the proximal tubule. In contrast to the fluid, which is isosmotic in the proximal tubule, the fluid leaving the loop of Henle is hypoosmotic because the descending limb is highly water permeable, whereas the ascending limb is impermeable to water. Now, the fluid which is leaving the early or which is entering the early part of the distal convoluted tubule is hypoosmolar. The osmolarity is close to 100 millimoles because more of the solutes are reabsorbed in the loop of Henle compared to water. Now, in the loop of Henle, again, sodium is absorbed into the cell along with chloride and potassium. Again, this sodium exits the cell independent to potassium and chloride through Na plus K plus ATPase, and the potassium and chloride exit the cell independently and as a part of K plus and chloride minus co-transporter. The movement of sodium, potassium, calcium, magnesium, and NH4 plus also takes place across the membrane because of the potential gradient, the membrane potential gradient that exists from the exterior of the cell to the interior of the cell. So the potential gradient also partly helps reabsorption of solutes. This sodium potassium chloride co-transporter can be blocked by your drugs like your furosemide. Most of the sodium, potassium, chloride, magnesium are again refiltered in the loop of Henle, of which magnesium, that is close to 65% of the magnesium, is reabsorbed or refiltered from the loop of Henle. The distal nephron, as I said, is both structurally, that is anatomically and functionally different from the proximal nephron in many ways. The distal nephron reabsorbs much smaller amounts of salt and water. The distal nephron will have tight junctions, and it can establish steeper gradients for salt and water. That is, based on the functioning of the distal nephron, you can excrete urine which whose osmolality can vary as low as 100 to 1400. Sodium and water reabsorption, unlike the distal, unlike the proximal nephron, in the distal nephron are not coupled. The sodium and water reabsorption is uncoupled in the distal nephron. The absorption in the proximal tubule is overall a very coarse process, whereas in the distal nephron, it is a much finer process. In the distal nephron, sodium enters the cell along with chloride. Like in any other part of the tubule, it leaves the cell in exchange to potassium, and this potassium exits the cell independently, and the chloride which enters along the sodium exits the cell independently. This sodium chloride co-transporter can be blocked by your thiazide diuretics. The collecting duct is the principal cell of potassium excretion. The sodium here enters independently because of the potential gradient that exists. Potassium is pumped into the cell from the blood in exchange to sodium, and part of it again enters back the blood, and part of it enters the tubule. The entry of potassium from the blood into the cell and into the urine is favored by the difference in the resting membrane potential that exists across the cell, and the movement is favored towards the urine because of the less difference in the resting membrane potential that is there at the luminal side of the membrane. This collecting duct plays an important role in the tubular excavation. Now, the main I would say the main function of the kidneys is to concentrate urine. That is, the kidneys have a special property of concentrating or diluting the urine. This ability to concentrate the urine osmotically is an important adaptation for life. Say for you to get rid of a certain solute, you need a solvent, that is to excrete a certain amount of sodium or potassium or uric acid or urea. You need certain amount of water to be excreted. For suppose you have to excrete 600 milliosmoles of the solute, you need a certain amount of fluid, say, which is roughly equal to 1.2 liters. Now, if the kidneys can excrete only isosmolar fluid to plasma, then the amount of solvent you need for excretion will be much higher. That means if your kidneys do not have the concentrating capacity, for you to excrete 600 osmoles, you will need 1 liter. Then for you to excrete 1200 osmoles, you will need 2 liters. So to avoid this, if the kidneys can concentrate, that means if the kidneys can excrete more of solute with lesser solvent, then you will be conserving water. That means the kidneys have a capacity to excrete much higher amounts of waste products with lesser amount of urine output. This is a unique property of the kidneys. This ability to concentrate, by this ability to concentrate, we are able to decrease the amount of water we are obliged to find and drink each day. Now, any change in the osmolarity will change the also alter the arginine vasopressin levels. If the plasma osmolarity increases, so the levels of the arginine vasopressin increases. The AVP, that is the arginine vasopressin, binds to the V2 receptors, and it helps in the conversion of ATP to CAMP, which in turn produces the protein kinase A, which in turn causes exocytosis of this intracellular vesicles that contain the aquaporin channels into the luminal cell membrane, thereby increasing the water permeability. This is an immediate effect which happens. And the delayed effect is this CAMP also causes gene transcription, resulting in an increased aquaporin 2 synthesis, which is a delayed effect of the arginine vasopressin. So whenever the plasma osmolarity increases, the arginine vasopressin level increases, and the aquaporin 2 expression is increased, and water is reabsorbed. So there is an increase in the water permeability. Now, last but not the least to understand is the counter current mechanism. Counter current mechanism is nothing but the gradient of osmolarity exists in the medulla, which is called as the counter current mechanism. Three parts of the kidney exhibit this counter current mechanism. One is the vasa recta, other is the loop of Henle, and other is the collecting duct. The loop of Henle has the counter current multipliers. The vasa recta has the counter current exchangers, and the collecting duct has the counter current, or I would not say counter current, they have the equilibrating devices. The loop of Henle, as I said, has a counter current multipliers. That means, for suppose your urine osmolarity is 200 here, it becomes 400 here, or 600. That is, it has a multiplying capacity. The vasa recta has a counter current exchange mechanisms. That is, it can absorb certain amount of water or solutes from the surrounding from the plasma, from the surrounding capillaries. And last but not the least, the collecting duct has the equilibrating devices. So we need a proper integration of the functioning of all these three counter current mechanisms, that is the multipliers, the exchangers, and the equilibrating mechanism to form a proper urine, that is a properly concentrated urine. The tubular fluid which is exiting out of the proximal tubule, as I said, is nearly iso-osmolar to plasma, which is around 285, and by the time it is exiting the loop of Henle and entering the distal part of the tubule, this osmolar, it becomes hypo-osmolar, that is the osmolarity drops to as low as 100. And again, because of the effect of arginine vasopressin, certain amount of water is either secreted or reabsorbed, and the osmolarity again reaches 285, that is iso-osmolar, by the time it enters the medulla. And because of the effect of arginine vasopressin, some amount of water is reabsorbed from the collecting duct, and the urine osmolarity steadily increases from 285 to roughly 1200. And if you look at the amount of water which is filtered in the glomerulus, that is close to 100 liters with an osmolarity of 285, the ultimate excreted product can have an osmolarity as high as 1200 liters. And to excrete this high osmolar load, as low as 0.5 liters of water is sufficient. So this is the concentrating capacity of the kidney, which is needed for adaptation to the life. And this concentrating capacity of the kidney comes from the counter current mechanisms which exist in the vasa recta, in the loop of Henle, and the collecting duct. And all these should function, all these mechanisms should function together for us to have, or for us to excrete low volume of fluid with the maximum amount of solute which needs to be excreted. This is the last slide, and hopefully I have given you a crisp brief and a clear understanding of the renal physiology. Thank you.